Hello and welcome to our webinar tonight. I am Thomas Farrington, the president and founder of the Prostate Health Education Network. And we're so pleased that you were able to join us this evening for our Talk with the Doctor series. This is the first in a series of monthly programs that we will broadcast that's really focused on the needs of the patients, the survivors, the wives, and caregivers, and others. And we want to develop a good, intimate relationship with our audience so that you feel free to talk with our doctors this evening. So I really want to thank you for joining us again this evening. And I'd like to begin by thanking our sponsors who've been so supportive of FIN efforts and helping us to make this program and many of our other programs available. So you will see our sponsors on the screen here. And these organizations really make it possible for us to provide our webinars, make it possible for us to do a number of education and outreach activities across the country. So sponsors, thank you so very much for all of the support that you provide. Now, I want to spend a couple of minutes talking about how this program will be conducted. We will initially have presentations, brief presentations by our doctors this evening. And once we finish those presentations, we will open up this program to our audience for your questions. Now, during the doctor's presentation, if you have a question, please submit that question at that time. However, we will hold all answers to your questions until the end of the program. But so don't hesitate to submit your questions, because we do really want to entertain your questions and really give a lot of thought to the things that you're concerned about in the audience. So at this time, I'm going to introduce our panelists. We have our panelists that you will see on the screen. We have Dr. Kevin Moses. Dr. Moses is Associate Professor of Urology at Vanderbilt Ingram Cancer Institute out of Nashville, Tennessee. And Dr. Moses will speak on how prostate cancer early detection can save your life. Dr. Keith Crawford, who is FIN's Director of Clinical Trials and Patient Education here in Boston. And Dr. Crawford will speak on making clinical trials work for you. And we have Dr. Adam Murphy, who's Associate Professor of Urology and Preventive Medicine at Northwestern University Feinberg School of Medicine in Chicago. And Dr. Murphy is going to speak on why vitamin D is important. So this is our lineup. I know each of these gentlemen, and I just like to say that they're all very accomplished in their areas. And we're pleased and honored that they were able to join us this evening. So at this point, we're going to kick off the program, the presentation, with Dr. Moses from Vanderbilt. Dr. Moses.
Thank you very much, Mr. Farrington and everybody at FIN. We really appreciate all the efforts that you've done nationwide. And thank you for inviting me to this presentation. I will share the screen. And is everybody able to see the screen? Okay. So as Mr. Farrington said, this presentation is how prostate cancer screening and early detection can save your life. And so we'll go over some of the basics about the prostate and prostate cancer, and then a little bit about data showing the importance of screening. I will not talk a lot about treatment, but if there are questions about that later on, we can get into that. These are my disclosures. So briefly, just to everybody can know, the prostate sits just below the bladder, and the urine goes through the urethra, which is in the middle of the prostate. It also sits just in front of the rectum, so that's why when the doctor examines the prostate, they put a finger in the rectum to feel that. And the function, a lot of people don't necessarily know, it's really what's called a sex accessory organ. It produces a fluid that helps to break down semen so that the or helps down to break the fluid so the semen can do its job in the female genital urinary tract. It does contain a portion of the urethra where the urine passes through. At puberty, until about your mid-20s, it's about 20 grams, which is the size of a walnut, but it can grow as we get older. So some men with or without prostate cancer may experience some changes in their urinary function due to the growth of the prostate. Some basics about prostate cancer: it is the most common solid organ cancer in men, number one, and is the second most common cause of cancer death in men. Currently, it is more prevalent and more aggressive in Black men. Black men in the US have the highest incidence in the world and over 2 times the death rate compared to white men. And much of this is due to Black men being less likely to receive screening or early detection and being less likely to receive treatment for prostate cancer. And when you're talking about screening for prostate cancer, the 2 ways that this is done is the PSA, or the prostate specific antigen, and this is a blood test, and the DRE, which is the digital rectal exam, which is self-explanatory. Just briefly, I'll go over the current screening guidelines. As of now, the American Urological Association recommends shared decision-making for men aged 55 to 69 with a normal life expectancy. And we define this as someone who has at least 10 years of life expectancy. They do recommend selected screening in men at a younger age, from 40 to 55, if they are at higher risk. And this includes men with a positive family history, such as a father, brothers, and in Black men. They do state that some men who are 70 and older and in excellent health may benefit from screening, but this needs to be a very selective population. The National Comprehensive Cancer Network also recommends shared decision-making. Their age range is a little more expansive, from 45 to 75. And they also state that frequency of testing can be lowered or lengthened in between times based on their baseline measurement. Again, they will give the option for select screening in very healthy men older than 75. But again, these men need to be in very good physical condition. Lastly, the United States Preventive Services Task Force has upgraded their screening recommendation from a D, which was not recommended, to a C. And this again emphasizes shared decision-making. So men aged 55 to 69 who are in reasonable health can discuss risks and benefits of screening if they wish to consider with their physician. Now, part of the reason for screening is that screening can allow for earlier stage of diagnosis. If you focus on the left hand of the screen, the majority of men are diagnosed with what's called localized disease, meaning that the cancer is only within the prostate. 13% of men, though, are diagnosed with disease that has spread to lymph nodes within the pelvis, and then 6% present with disease that has already metastasized or spread to other areas, such as the bone or other organs. Approximately 5% of men are unstaged at the time of diagnosis. This is important because if you focus on the right part of the screen, you can look at the 5-year relative survival based on the stage at diagnosis. As you can see, for localized and regional disease, these men should survive 5 years, up to 100%. However, you see a steep decline in survival down to 30% if there is distant disease. And the way to avoid being diagnosed at a late stage is through screening. As I stated before, the United States Preventive Services Task Force previously had a grade D recommendation, first in men over 75 and then in all men in 2011 and 2014. I'm not going to get too much detail on this graph, but on the left hand of the graph, you can see that the incidence of prostate cancer, depending on risk, was increasing over time. After 2011, you start to see a gradual decline. That top line shows a decline in the number of men who are diagnosed with low-risk disease. And this is a good thing because most men with low risk disease do not require treatment, or if they do receive treatment, they can have excellent survival. And so a decrease in this number is good, and that is what would prevent over-treatment and over-diagnosis. Unfortunately, though, you can see in the next two lines, which are intermediate and high-risk disease, those are also decreasing over time. That means fewer high-grade cancers are being diagnosed at an earlier stage, and thus these men are more at risk for spread of disease. And as we saw in the previous slide, your chance of survival of 5 years starts to decline significantly if that cancer is allowed to spread. In this slide, this shows some of the results of biopsy outcomes since the change of the USPSTF. And again, you see an increase of 5.94 risk in cancer overall, an increase in Gleason 4+3, and an increase in high risk depending on which modality you use to determine high risk, versus D'Amico versus Capra. Now, this was early data, but it was determined to be a really problematic trend, and this is increasing even to this day. There have been some studies looking at PSA screening, and the most reliable one is the European Randomized Study for Screening of Prostate Cancer, otherwise known as ERSPC. When the data was initially published at about 7 to 8 years, there was a difference in survival, but it was considered very narrow, and the risk of overdiagnosis and overtreatment was high. But in this more recent data shown here, the control group risk of death in the red line is now starting to separate from the group that received screening, now at 13 years. And the further along this goes, we start to see the impact of screening in a population of men. It's important to note that the ERSPC allow for screening every 2 to 3 years. So even without annual screening, these men are enjoying an improved survival. The other thing that has been noted is that with screening, and I'll show this last line here, the men who received screening were much less likely to present with metastatic disease or a PSA of 100. So if you look at the early group of men, and that's 0 to 3 years, the risk of metastatic disease or high PSA was 0.94, and 1 would be equal to an unscreened population. So really no difference. But if you go all the way to the last column, labeled 0 through 13, up to 13 years, that number is now 0.6. And what that means is there is a 40% reduction in the risk of presentation with metastatic disease or a PSA of over 100. And that is a significant reduction, even better than what is seen with mammography for breast cancer. And again, I'll refer back to the slide showing that your survival from localized disease to metastatic disease drops 70% at the 5-year mark. So this is a really critical piece of data. So if you review all of the screening patterns and what has happened since then, there has been some good. Number one, fewer low-grade cancers have been diagnosed. And so that prevents overdiagnosis of cancer that does not need to be treated and prevents overtreatment of men who have low-grade disease. There's possibly decreased anxiety over fluctuations in PSA levels. Some men don't have a stable PSA either because of prostate growth or infection. And importantly, there's less exposure to diagnostic and treatment risks. There are risks that are associated with diagnosing cancer with a biopsy and then also treatment with surgery or radiation or some form. There is some bad, though, that has happened over the last several years. We're potentially missing treatable, intermediate, and high-risk disease, and I'll define this later. There's decreased opportunity for refinement of screening tools. And additionally, it misses the opportunity for active surveillance of men with low-risk disease. And then importantly, in the Black population, Black men, those who are uninsured, and those who are lower education will see even lower screening rates. And as we stated before, these men are a high-risk population at being diagnosed with more advanced disease. So just briefly, I've been asked frequently, what is a normal PSA? And to that, there's not really an answer. There's not a cutoff for PSA where there is no cancer. And you can certainly have cancer with a PSA that's very low. But what you have to do is take into account the age of a man, the size of the prostate, and prior PSA measurements to compare against. And importantly, the age that I mentioned first, a PSA of 6 in a man in his 80s is not nearly as concerning as a PSA of 6 in a man in his 50s. And so they're all factors that need to be taken into account when you're discussing screening with your physician. If the PSA is concerning, your doctor may recommend a prostate biopsy to be performed. So what do you do if the PSA is elevated? If it's minimally elevated, you can repeat it in 3 to 6 months just to confirm if it's truly rising, or maybe it was a temporary rise due to infection or trauma. If there is evidence of infection from a urine culture, we do recommend giving antibiotics, and then you can repeat the PSA. Importantly, though, if there is no evidence of infection, antibiotics should not be reflexively given just because the PSA is elevated. And then if it is significantly elevated, consider imaging with an MRI and a prostate biopsy. This is how a biopsy is performed. There's an ultrasound that is used to visualize it, and we use a template to take biopsies of the prostate, which is then sent off to a pathologist to look at. And these are the patterns that they're looking. And usually you can't have just one pattern, but for the most part, there can be a mix of patterns. And so what the pathologist will do is take the 2 most common patterns and then add them together to give you your Gleason number. And so in this example, if it's mostly grade 3, which is low grade, and then a small portion is grade 4, which is a little bit higher, then you add that together and you would say the Gleason is Gleason 3 plus 4 equals 7. The vast majority of time, if you're going to get a Gleason number, it would range from 6 to 10. Very rarely do you see something less than 6 these days. I mentioned risk classification before, and just briefly, we'll look at how you define low, intermediate, and high risk. Low risk men have a PSA of less than 10, and the Gleason number is 6, and they have to have either a normal exam or they can have a small nodule of the prostate. You have to have all of these criteria to meet low risk. And as I mentioned before, a lot of these men do not require treatment. They can undergo active surveillance. Intermediate risk can be any of the following: a PSA of 10 to 20, a Gleason sum of 7, or a large nodule or a disease that's felt on both sides of the prostate. And then to meet higher risk classification, the PSA has to be over 20, or the Gleason number from 8 to 10, or a large nodule that can be felt outside the border of the prostate, or evidence of extraprostatic disease. So just to summarize, prostate cancer screening should be done in a shared decision-making model with the man and his physician, and screening should be performed using the digital rectal exam and the PSA blood test. Data has shown that changing in PSA screening patterns may affect survival, and importantly, screening trials in Europe have shown that screening can reduce the risk of death and the risk of metastatic disease over time. Prostate cancer, when diagnosed at an early stage, may not even require treatment, or certainly can be watched with an active surveillance protocol. Otherwise, early stage prostate cancer has an excellent survival in men. Thank you for your attention, and we'll take questions at the end of the presentation.
Thank you, Dr. Moses. Dr. Moses presented some very interesting information and materials. I think one of the key pieces of the materials that he presented had to do with the different guidelines or recommendation by different bodies. He talked about what the U.S. Preventive Services Task Force recommendation is, what the NCCN, that's the National Comprehensive Cancer Network, the American Urological Association, and each one of these bodies would typically have their own guidelines. However, they all do recognize that men at high risk need special attention. All African-American men are designated as being high risk for prostate cancer. So, so I would say that African-American men and other men with a family history, or men who have been exposed to Agent Orange, you are in that high risk category, and you are really, the earlier the better for screening and establishing a PSA baseline. So, so I want you to keep that in mind. And also, I'm sure that you have many good questions for Dr. Moses. So, so send those questions in, and we'll address those at the end of the program. Thank you again, Dr. Moses, for that outstanding presentation. Now, I would like to ask Dr. Keith Crawford to present on how you make clinical trials work for you. Dr. Crawford.
Thank you, Tom. I'm about to switch over into the presentation. So, good evening, everyone. My topic this evening is making clinical trials work for you. I'm Keith Crawford, Director of Clinical Trials and Education at Finn, and I'm happy you're joining us this evening. First, I wanted to take a step back. When we're talking about the estimated new cases and deaths of prostate cancer in 2020, if we look at all the men, it's estimated somewhere close to 192,000 new cancer cases in 2020, of which prostate cancer represents a little bit over, or 10%. When you look at African American men, the incidence of prostate cancer is about over or close to 30,000. And this represents close to 30% of all new cancer cases. And if you compare death, the new death in relationship to in 2020, you'll find that it's predicted that there'll be over 33,000 new cases of people dying, of which 5.5% of those will be of all the cancer cases. Well, in contrast to African American men, there's predicted to be over 5,000 deaths, of which represent about 15% of all cancer deaths. Now, if we take a step further and we do a comparisons between African American men and Caucasian men, and this is what's very striking. If you look per 100,000 men, the number of new cases in 2020 represent 176 per 100,000 men compared to 102 per 100,000 men for white men. If you look at the rate of death that's predicted, it's predicted that per 100,000 men, 38 Black men will die compared to 18 for Caucasians. And I think the most important thing here is to take in consideration this. 70% African American have a 73% higher incidence rate than white men. And the death rate for African American men is about 2.2 times greater. So this is important because this is the largest racial disparity for any major cancer. Now, you have prostate cancer. Now, whether it's newly diagnosed, a change in condition, recurrence of cancer, or whether or not you're faced with metastatic disease, you want the best treatment, the best care, and the best cost. So how are you going to do this? If you want this best treatment, best care at a low cost, even a no cost, you really have to think about clinical trials, because it's the only thing out there that gives you this comprehensive everything that you would want. So the question is now, what is a clinical trial? A clinical trial is a study performed by human volunteers just to determine if a new therapy is better than the best treatment, standard of care available at this time. Now, clinical trials can be divided up into 4 phases. Phase 1 clinical trial is just aimed at looking for the best dose and with a new drug with the fewest side effects. Then phase 2 and 4, their aim is just to determine how this new therapy performs. But in clinical trials, you, the study participant, are guaranteed to receive at a minimum the best standard care. So I say it again, when you participate, you're guaranteed to receive at a minimum the best standard of care. Now, when we start talking about best treatments, clinical trials compare new therapies to the standard of care. All men participating in prostate cancer clinical trials will receive the best treatment available at that time. Either standard of care plus a placebo or standard care plus new treatment, but you will get standard of care in a clinical trial. The standard of care are guidelines and protocols that experts have agreed are appropriate. These are the best practices that physicians use to provide care. Now, you want best care. And best care is that you'll get in clinical trials is there's increased patient monitoring. You see, researchers are conducting these clinical trials and want their studies to be successful. And to do this, participants, you, are monitored regularly, making sure that the trial guidelines are followed closely. Because of this, clinical trial participation receives more attention than a patient who does not participate in a clinical trial. So, best care, better interaction with your clinicians, your healthcare provider. Next, you want basically a good cost, if no cost. So when we look at clinical trials, and this is why it's attractive also, is that clinical trials normally do not cost anything for the participant, for you. Even though clinical trials cost money to run, sponsors of clinical trials and the participant's insurance company will typically cover all the costs. So that's when we talk about best cost, is low cost or no cost. Now, who can participate? There are a lot of trials for prostate cancer out there. And if you fall into a category of low risk prostate cancer or low to intermediate risk prostate cancer or high risk, do you have recurrence of disease? Or if you've even been treated by radiation surgery, there are clinical trials out there. And then those people who have had metastatic disease, who are castration resistant, and those people who are castration resistant, meaning that they're not responding very well to a hormonal treatment. There are clinical trials there. So take the time and really think about looking for clinical trials. Now, this is the big question. In the back of everyone's mind, are clinical trials safe? Now, to prevent what took place at Tuskegee, all clinical trials in the United States must be approved and monitored by an institutional review board, this IRB. Now, an IRB is an independent committee of physicians, statisticians, community advocates like Finn, and other professionals. Now, the IRB ensures that the clinical trial is ethical, the right type of study participants are, and that the study participants are protected. And so that's what we consider to be key. Study participants are protected. All institutions that conduct or support biomedical research involving humans must, by federal regulations, have an IRB that initially approves and just watches over reviews the research that's going on. So now you have two areas of close monitoring for your care. One, it's more at the healthcare provider and you, and then you have an advisory, an institutional review board that oversees research in the United States in a clinical trial. Now, African-American men in clinical trials. Now, currently, African-American men represent about 4% of the total prostate cancer clinical trial participants. Now, we make up about 13% of the population, but we only make up 4%. A recent study out of Harvard School of Public Health suggests that African-American men should represent, at a minimum, 22% of the participants in prostate cancer clinical trials. So that's a big gap, and that's a big gap to fill. And so that's why it's important for you to be aware of these options with clinical trials. Again, African-American men, when it comes to clinical trials, respond differently to different treatments. Now, an example of which is the PROCEED clinical trial, which demonstrated that African-American men receiving this immunotherapy. So an immunotherapy is using the body's immune system to attack the cancer. In this case, using immunotherapy for castration-resistant prostate cancer. Now, Black men lived 9.5 months longer than white men with metastatic castration-resistant prostate cancer. So why is this important? You're sitting there, I'm telling you to participate in clinical trials. Why it's important? We know you're going to get the best treatment, the best care at a low cost, and it's safe. It's important because for African Americans to participate in clinical trials, and I'm going to give you this example. So a immunotherapy, Provenge, now it was initially registered with the FDA in 2003. 7 years later, the FDA gives it approval in 2010. Now, during that period of time, there was evidence that Black males were outperforming their counterparts or white counterparts in this therapy, but it wasn't enough participation by African-American men to really make sense of what they were finding. So because of that inadequate number of participating African-American men in the Provenge clinical trials, it took 7 years to get enough information to support the earlier discovery that African-American men might live longer with this therapy. So between 2010 to 2017, data had to be collected. And a lot of African-American men were not exposed, had an opportunity to discuss this particular treatment because there wasn't enough information as it relates to them. So furthermore, if more African-American men were involved in this clinical trial, more men, especially African-American men, could have taken advantage of this promising immunotherapy. So we give you this information, we tell you it's there. So how do you get to this information? Now, a lot of people can go to clinicaltrials.gov, and that may be complicated and may frustrate you going through there. FIN, recognizing this, has established FIN Clinical Trial Rally. And I'm giving you a very general overview of clinical trials. But for more information, you can go to fintrials.org. To help you when you go to fintrial.org, we have established a tool we call Find Your Trial Tool, the FIGHT tool. And this tool is divided up into 6 searchable categories defined by disease type and treatment. Each category contains phase 2 to phase 4 prostate cancer clinical trials, which are actively recruiting participants. Many clinical trials make clinical trials work for you. And that's what we're saying right now. We're providing you this information because we know that to gain access to new research treatments before they are widely available, best treatment. Participate in well-designed, well-executed, well-monitored research studies, best care. Pay nothing for your prostate cancer or for your cancer care. That's your best cost. So it's important to walk away with these key points. But lastly, participating in a clinical trial helps you, but it also helps other people. Because you're going to get these results help the future or participation or designing therapies that may be good for African American men or may not, may have side effects, but you have to participate. And the other point that I want to bring up is when participating in clinical trials, you will at minimum at least get the standard of care, which is the best care. So clinical trials can work for you. They'll give you an opportunity to get the best treatment, the best care at a low cost or no cost. And that's why it's important to participate in clinical trials. But just remember, as I close, knowledge is the best defense against prostate cancer. So take a look at our website, take a look at fintrials.org, and call us if you need us. Thank you.
Thank you, Dr. Crawford. And I hope you understood the key point that Dr. Crawford was making. Number one, we have a big initiative at FIN to increase African-American participation in clinical trials because we think it's important to eliminate the racial disparity. There are treatments that may work very well for us, better than for other men, as Dr. Crawford pointed out with the Provence trial. And we need this information, not 7 years later or 20 years later, and sometimes never do we get this information if we're not there actively participating in these trials. So make clinical trials work for you. You need to think of clinical trial as a tool. When you think of a treatment that you need, newly diagnosed or metastatic, look at a clinical trial. Make that part of your consideration. So Dr. Crawford, thank you for that presentation. And again, I encourage you, the audience, to submit your questions that you may have for Dr. Crawford. Now I'd like to introduce Dr. Adam Murphy, and Dr. Murphy will make his presentation about why vitamin D is important. Dr. Murphy, you need to unmute. Good.
Hi, everybody. I'm Adam Murphy from Northwestern Urology. Hello, everybody, all the other presenters as well. I'm a fan of each of you. I am Adam Murphy. I work on as a urologist half the time, and I work as a health disparities researcher the other half of the time, and that's how I kind of know Dr. Moses. He inspired me to actually do a research study after a conversation on Twitter. So I'm really excited to talk about some of that research with him too. But this is an old study that started when I was actually a research fellow in Dr. Rick Kittle's lab. For people who don't know who Dr. Rick Kittles is, I know Dr. Farrington does and Dr. Moses does. He was one of the few Blacks on the Human Genome Project. And I got to work with him at University of Chicago when I was a urology resident for a year. And then again, when he went to UIC and founded the Institute of Human Genetics there. And so the idea was the established risk factors for prostate cancer, which Dr. Moses has already told you about, are age, family history, and African ancestry, or being African American. And those are shared with actually vitamin D deficiency. So we've known that since the 90s. And given the fact that Blacks have higher risk of prostate cancer and then more than double the mortality rate, the question was, is vitamin D a common link between the two? And while people love the fact that African-American skin is resistant to the sun, and keeps Mr. Farrington looking like he's 40 forever, It also is a impediment for sun rays making vitamin D in our skin. And so I got this one published in a decent journal, but it involved quite a few people who helped me put this together, people at county hospitals, people at the VA, and then one of the fathers of PSA is William Catalona. He and Dr. Kittles were my co-mentors on this grant, my first grant. And it was essentially looking at men who already had radical prostatectomy and using those same NCCN risk categories that Dr. Moses talked about. We wanted to see if people who had vitamin D deficiency before their surgery were more likely to have kind of bad outcomes when you compare their biopsy findings to what you actually saw when you had the entire prostate in front of you. And this is the shorthand of it. We had about 190 men in total. And if you look across all those risk groups, we talked about low risk and intermediate risk and high risk, and you look at what you think is localized disease, you find that men who had vitamin D deficiency, which at that time was defined as less than 30 nanograms per milliliter, the doctors now know that they tried to cut it back down to 20 nanograms per milliliter because we had developed a pandemic just with the definition of vitamin D deficiency when people started looking at it. But anyway, no matter what, having deficiency more than doubled the odds of having a bad pathologic feature seen at the time of your surgery, which was a higher grade tumor, Gleason 4+3 or higher on your prostatectomy, or you had evidence that the cancer had escaped the outer capsule of the prostate and actually extended beyond it. So that was across all risk groups, whether it was low, intermediate, or high risk group. And that's when you control for age and serum PSA, which is the test we use to screen for prostate cancer, and the digital rectal exam, or the prostate exam that so many like to avoid, but it's really important for prostate cancer screening. So that gave some people pause to think that vitamin D had a role, because initially when they had done the studies on vitamin D, they had done it the way you're supposed to, looking at multiple sites across the country. And like Dr. Crawford said, they had very low enrollment of African Americans in the studies. So when you look across the countries, what was happening is you would find a weak association with vitamin D and prostate cancer aggressiveness. But that's because you would go to sunny places like California, UCSF, and University of South Florida or Tampa, and get all these people who were sun exposed all the time and very, very rarely had vitamin D deficiency. Or if they did, they had it just for a couple months. So we were able to find it because we recruited all of our men from Chicago. And we have 6 months of winter. It's construction and winter in Chicago. So this got us back on the map. And so people would wonder, well, what does vitamin D actually do in prostate tumors? And when I'm in less diverse audiences, people oftentimes think this is me. And then I realize that that's not me, that's Eddie Murphy. You guys probably recognize the difference. A lot of people don't. But in any case, I wanted to figure out next what vitamin D did in people. And there's a lot of different pathways that could affect prostate cancer. And Dr. Crawford mentioned inflammation as one of them, which is why Provenge works probably, is that a lot of African-American prostate cancer, we think arises from an inflammation over time, chronically. It may be from dietary exposures or red meat or infections that have happened, but in any case, inflammation is often the prostate, and that's one pathway to prostate cancer. And subduing or reactivating their immune system allows their immune system to attack the prostate cancer better with Provenge. But there's also proliferation or just regular growth or doubling of the cells. So this is what we went for, which was growth. So the most active version of vitamin D is called 125 dihydroxy vitamin D. The type you get over the counter in pills is not even hydroxylated at all. It's just vitamin D3, and then it gets activated once in the kidneys and once in the liver to become the most active version. And then Ki-67 is an independent marker of prostate cancer mortality, but it's also a marker of tumor growth or proliferation. It's made in the nucleus of the cell, and it's only active when the cell is dividing and copying itself. And so what I'm just showing here is that people who, no matter what their PSA level is, if they have a higher level of this tumor marker, this Ki-67, their mortality rate is higher or their survival is lower, and quite a bit lower, almost 50% lower when you have this high Ki-67 in your prostate tumor. And here's an example of how it looks under the microscope. This is from my own study. We recruited these men from the Jesse Brown VA in Chicago. And these are people who are similar ages. One's white or European American, one's African American or Black. Similar PSAs, less than 6. And they're both taking vitamin D, and the European American guy is actually taking less than recommended, and the African American is taking more than is recommended at 1,400 international units a day. At this time, it was only 400 international units per day that was recommended. And you can see he still was deficient by the 30 definition and barely sufficient by the 20 definition because of beautiful melanin probably, and lactose intolerance also. The brown dots here are the dividing cells, or the ones that are proliferating. And you can see that it's very low proliferation, which is normal for prostate cancer in this white patients with Gleason 3+4. And then there's a lot of proliferation in this African-American 3+4. And you actually see that there's some T3A, means that there's some extension of the prostate cancer outside of the gland itself. So we had 180 men who underwent surgery. We did this staining, just like we just showed you, on 119 of those men, and actually I had a coordinator count the number of brown dots per 1,000 cells, per 1,000 nuclei. And that's how we came up with how much of the tumor was proliferating. And the pathologist that I showed on the cover screen was Dr. Bala, who helped me do this work. This is just showing you, we divided the vitamin D into three different groups, and you see that they're similar ages. And you see here at first that the tumors had very fluctuant levels of this proliferation. So it was very random. They didn't see them to be a real pattern to this. But remember, these include Blacks and whites in different grades. So I can't use this as proof that vitamin D affects the tumor proliferation rates, because higher grade tumors grow faster, I'm sorry. And also African American tumors may have different levels of vitamin D, so you don't know how it's mixed in. But this is what I wanted to show you. Essentially, these red arrows are where the money is. These are normal prostate epithelium, normal prostate tissue in people who had cancer. We went to the other side of their prostate, same area, to find benign, non-cancerous tissue. This is what this is pointing to. When you raised people's vitamin D levels in their serum, their blood, their proliferation rate went down when you got to high levels of vitamin D intake. And if you looked at people who had looked at their tumors, you see that the effect is even more dramatic. So that when you had high levels of 125, the most active version of vitamin D in their serum, it really reduced the rate of growth. This up above here is just showing that serum and prostatic levels correlate with each other, and 125 and 25 correlate as well. So that's all I have for you about that. So if there are any questions, I think Mr. Farrington is going to take us through the Q&A answer session, but I'm here for that. Oh, this is extra stuff in case you all have questions about other parts.
Thank you, Dr. Murphy. What Dr. Murphy has pointed out is that vitamin D level really has an impact on a prostate cancer tumor. And men with appropriate vitamin D levels do better than men who do not have those levels. And African American men, we tend to have low vitamin D, and it's an easy test. Once I found out about vitamin D from Dr. Murphy, I think some years ago, I had vitamin D tests and found out that I was vitamin D deficient. So I've been taking 2,000 units since. And so for those in the audience, it is something, it's an easy test, and it's something that you need to be aware of because this is something that you can impact. You can fix this and help yourself with that. So again, if you have questions for Dr. Murphy on vitamin D, then please let us know those questions. So we have finished this part of our programs. You've seen the presentations of our guest panelists, and I think they've done a good job for good information out there. We now know that Eddie Murphy is really not Eddie, but is Adam. So he's trying to take Adam's place. So okay, we know there's a connection between the Murphys. So now we're going to go with questions, and I see that we do have some questions. So we're going to take our times and answer questions that we have. There's a question about the ACS guidelines, and I'll ask Dr. Moses to answer that question. I guess, Dr. Moses, you presented the guidelines of some of the organizations, but no one saw the American Cancer Society guidelines, and they do have a separate guideline. So you want to address that question?
Yeah, I can take that. The American Cancer Society guidelines are pretty similar to the AUA's. Number one is important. All the guidelines recommend informed decision-making and shared decision-making. So that means speaking with your physician about the risk and benefits of screening. And then once that's done, they recommend starting at age of 50 for men who are at average risk and have reasonable life expectancy. If men are at higher risk, and that includes African-American men or those with a first-degree relative or somebody diagnosed younger than 65, they recommend starting at 45. And then for men who have a first-degree relative who is diagnosed at an early age, like in their 40s or 50s, they recommend starting at age 40. So they're actually a little more detailed as in regards to risk category, risk according to first-degree relative, and starting somewhat earlier based on a first-degree relative or African-American race.
Thank you, Dr. Moses. We have a number of questions on whether the slides and the presentation will be available following our program this evening. This whole program is being recorded. It will be available on our website within a few days, and it will also forever be available on our Fin television series. So you will be able to access this program. And it will be also available on Facebook. We will promote this on Facebook within a couple of days. So you will have access to this program. Dr. Crawford, I have a question for you. What kind of clinical trial will be available to a post-surgical prostatectomy and radiation patient?
That's an excellent question. And I think the best way to really approach this question is if we go to fintrials.org, there's a category just for that population of patients, prostate cancer survivors. It's broken up between prostate cancer surgery and cancer and radiation. But if you look into that particular category, there are a wide variety of new clinical trials that are coming out or that are actively recruiting, whether it's the use of PARP inhibitors or immunotherapies, some of the new therapies that are out there. So the best way to approach this is as I mentioned before, is take a look, go to fintrials.org. And if you scroll down to the bottom of your page, you'll see our fight tool. And just identify that category that shows a category specifically for cancer, surgery, post-surgery, and radiation. And if you click on that, it'll give you a list of a variety of actively enrolling clinical trials. So, but remember, the point that I want to make is, in the clinical trials, you're going to get the best care, the standard of care. And I'm going to repeat it again. Best care, best treatment, best care at a low cost. And take a look at our fintrials.org site and look at our search tool. I think that that's the best way to answer that question.
Thank you, Dr. Crawford. And I'd like to emphasize that. Go to fintrials.org and look around. I'm sure you will be able to find a number of trials that are available in that category. I have some more questions. 2 years after prostatectomy, PSA is doubling every 15 weeks, now at 0.35. I could not tolerate radiation. My urologist says to wait until it gets to 5 and then go on hormone therapy. Is there anything I can do now, diet or anything else? And Dr. Murphy, what are your thoughts on that question?
For dietary things, you know, it's interesting. There's quite a bit of anecdotal things out there. Vitamin D is fine to put in there. What's clearly associated with kind of cancer risk, even from the World Health Organization's perspective, is red meat intake is a big contributor to cancer risk. So reducing that, reducing processed meats, especially like sausage, bacon, kind of smoked meats, deli meats are bad things, and then increasing your fruits and vegetables in general to 3 to 5 servings per day. So these are things that tomatoes look like a magic pill. It is not. So we always tell people to kind of vary the color of their fruits and vegetables. And then the thing that was kind of interesting to me was, although vitamin D is helpful, turns out that milk intake is not necessarily helpful. It's actually kind of a risk factor. So if you drink more than 1 to 2 servings of dairy a day, that's associated with increased risk of cancer. I think those are reasonable things to avoid. If you are a smoker, reducing smoking. If you are a drinker, reducing alcohol intake. It doesn't seem like you have to go cold turkey and off, but 1 serving or 2 in a day is a max. It's probably okay. Those are the things that I really kind of warn people on. And then just maintaining a healthy weight, not allowing yourself to get heavy in sometimes people get depressed or downtrodden after diagnoses like this. And I think it's really important to kind of maintain your health. And most people who end up with prostate cancer, even if it's fairly aggressive, are more likely to die of cardiovascular disease than they are to die of prostate cancer. So doing things that are smart for overall health makes a lot of sense.
Thank you, Dr. Murphy.
Mr. Farrington, before you go further, I want to clarify. Did the man say his PSA doubling time is 15 weeks or 15 months?
He says 15 weeks.
Okay. So that is a really rapid, that means his doubling time is less than 4 months. Even though his PSA is low, that's someone who's at risk for metastatic disease. And so he needs to get imaging, either a CAT scan with a bone scan, or if he has access to something like the Prostascent or Actamin scan or PSMA scan, that's something that needs to be done now. And then when his PSA gets to 2, if all that imaging is negative, he can repeat it then. and then repeat at 5. He certainly probably will be facing hormone therapy at some point, but definitely with a doubling time that rapid, needs to keep a close watch on imaging for metastatic disease.
Okay. Thank you, Dr. Moses. I have another question is, upon getting out of bed in the morning and placing my feet on the floor to stand up from a sitting position on the side of the bed, I experience pain in my lower back. The pain diminishes and stops within approximately 60 to 75 minutes. I am pain-free the rest of the day and carry out my regular activities. This has been a regular experience for 6+ months. Any thoughts on that from our panelists?
So that's much more likely to be musculoskeletal in origin. So just like arthritis or something like that, once you kind of work the joints out and get moving, that pain can get better. Men who have disease in their bones from prostate cancer, that's usually a pretty constant symptom, meaning that it doesn't just get better with a little bit of movement or time. Now, obviously this, if that man is at a particular age or and wishes to do PSA testing, that's certainly something that can be checked. But you have to take what's common is common, and so low back pain and sort of aches in the joints are much more common than metastatic cancer.
Okay, thank you, Dr. Moses. I have another question here. What is the life expectancy of a person with prostate cancer that hasn't spread? I know that's a pretty broad question, but someone asked it, so we'll try to answer that. Who would like to weigh in on that one?
I think we also could say something. It depends a little bit on your stage, but if it actually is localized, you have to get out 10 years before you start to see big drops in mortality. So the way we tend to think of it is that if you were on a transplant list and you had prostate cancer that was localized, it doesn't necessarily change your criteria for whether you be a candidate. So most people don't think it drops it very much.
Mm-hmm. Okay, thank you. What are the chances of a urinary sphincter reversal in the next few years? I think I'm reading that right. What are the chances of a urinary sphincter reversal in the next few years? That's what I see written here. I'm not sure how to interpret that question.
Yeah, I'm not sure I understand what they mean by
reversal. Is it not working now, or do they mean it's
not
working?
Yeah, I'm not sure, but that's.
I mean, a urinary sphincter, once you get past the early risk of things like erosion or infection, if it's functioning well, it should last for years, 5, 10, 15 years. At some point, it will stop to work and it can be replaced. So if the sphincter stops working, it can be replaced. I'm not sure they mean by reversal, but certainly replacement can be done if it stops functioning.
Okay, thank you. Another question, after radical prostatectomy, how often should you have the PSA monitored, and at what point are you considered cured? That's a good question. I'm sure everybody would like to weigh in on that. Dr. Moses and then Dr. Murphy.
Dr. Moses, you got this.
So a lot of it depends on what the pathology is after your surgery. As a general rule, it gets checked at about 6 weeks after surgery and then 3 months after surgery. And then again, depending on what your preoperative and pathologic results were, your screening intensity is based on that. So for low risk, I usually will check every 6 months, maybe for a couple of years, and then do annually. But for intermediate and high risk, I'll check every 6 months for a little bit longer, up to 2 or 3 years, and then maybe switch to annual if it remains undetectable. Theoretically, you should continue checking PSA because even in low-risk patients, there is risk of PSA recurrence. But again, in low-risk men, that chance is so low that really after 5 years or 10 years, whichever you pick, if it stays undetectable that long, you can probably stop. For high risk men, I probably would recommend, because if you look at the calculations for PSA recurrence, the higher that risk goes, the risk of PSA recurrence is anywhere from 50 to 80%. And so in those men, I would continue surveillance of their PSAs, at least annually.
Thank you. I have one here for Dr. Murphy. Is the potency of vitamin D medication higher in a prescription form than pills available off the shelf?
The only thing that's really different between over the counter and off the shelf is really whether they're vitamin D3 or not. So D2 is the one that you get from it's cheaply produced. D3 is the one that's kind of in the little oil capsule immersions, and it's a little more expensive, but it's more bioavailable. And over the counter, you can get from 400 up to 10,000 a day over the counter pretty easily at a Walgreens or a CVS. And you can even get them in multivitamins pretty easily now, where it's like a Nature Made plus 2,000 units of vitamin D added into it. If the reason why I think that the prescription bit, it makes sense, is more sense, is because it means that your doctor actually measured your vitamin D at some point to know what your level is, and then gave you a level that kind of works for you. The study suggests that you're pretty non-toxic at a really high range of vitamin Ds, anywhere between 600 and 10,000 a day is safe if you don't have liver and kidney failure. So you have a wide range of wiggle room there. But ideally, if you're just guessing, 2,000 international units a day is a good starting point. And that's what's in a lot of the over-the-counter supplements.
Thank you, Dr. Murphy. Another question, after diagnosis with prostate cancer and having a radical prostatectomy, are you at increased risk for the coronavirus?
It's interesting. I'm going to just say this because it's interesting. There's some links to certain comorbid conditions and coronavirus, like hypertension and diabetes. And diabetes is linked to prostate cancer weekly. So you could, if you have prostate cancer, you may also have risk of coronavirus. But I don't know of anything directly there. It turns out that people who are on metastatic prostate cancer medications like Lupron, Eligard, Zoladex, those kinds of things, were protected from COVID infection because their testosterone were suppressed to such a level that it actually reduced the receptor for taking up COVID into the lungs, called TMPRSS, which is really common in prostate cancer kind of progression. So there's some weird associations.
Could you repeat that point again?
I'm sorry.
Yes.
So they did this, the whole thing with coronavirus has been moving really, really fast. And Dr. Moses is I'm sure, really, really aware of this cool little fact because he's in cancer more than I am. But when when I was looking at this, it turns out that the people who were taking androgen deprivation therapy for metastatic prostate cancer were actually protected from getting coronavirus. They had a lower prevalence of coronavirus than you would expect. And so when they came up with the mechanism with it, it turned out that men had 60% of the people who were infected with coronavirus. And so it came to people's minds that maybe testosterone was a risk factor for getting coronavirus. And it turns out that seems to be the case, with the highest risk people being African-American men for coronavirus infection. And so if you suppress testosterone levels enough, some people have shown that you can lower TMPRSS expression. TMPRSS is the molecule, one of the molecules that activates the spike protein to be taken up from the coronavirus into the lung or nasal epithelium. So basically having low testosterone is protective.
Okay. Thank you.
And now the point that was the reason why there was such a disparity or difference between women contracting coronavirus versus men.
All right, thank you. Thank you, doctors. And I think this would be our last question. On average, how long does it take to regain continence and sexual potency after radical prostatectomy?
All right, I'll take that one. A lot of it depends on age. So younger men, and at least in the prostate cancer world, younger is 65 or younger. Those men should regain at least most of their continence within 3 to 6 months. And what I say about most continence, I'm at most wearing 1 pad a day or having some leakage if they have a full bladder and laugh really hard or stand up quickly or swing a golf club. For older men, it takes longer. It can be up to a year before you truly know your final continence level. Now, men who have severe leakage and it doesn't get better within 3 to 6 months, those men are not going to do well, and they'll likely need some type of intervention. But as long as you're improving, again, younger men should be pretty continent within 3 to 6 months. Older men, it may take up to a year and a half. As far as sexual function, again, age is a factor, and how good sexual function was before surgery. So if you had excellent sexual function before and you're a younger man, it should take, again, about 3 to 6 months. And even among those men, about 25 to 50% will need medication in order to have a maximal erection. For older men, again, that can take longer, and it never gets back to where it was before. And so I kind of jokingly use the analogy where you playing pool with a stick or a rope before surgery. If you're playing with a stick, then you've got some chance of regaining function. It also depends on what kind of surgery you have, if you had nerve sparing versus not nerve sparing. If you were playing with a rope before, it's going to be very difficult to regain any sort of usable function, and most of those men will require medication or even surgery to regain usable erectile function.
Thank you, Dr. Moses. At this point, we're going to end our Q&A session, but I don't want my audience, my online audience, to leave. Because we're going to take a poll. I'm going to launch a poll, and we want your feedback on the session. We love to get feedback so that we can make our next program better, and we just need to know how well we're doing, whether you like what we did or whether you did not like what we did. But before we do that, I want to thank Dr. Murphy, Dr. Moses, and Dr. Crawford for being with us today on this program. You did great presentations, and taking the time to answer these questions, I think, will benefit a lot of people. So I want our online audience to give our doctors a round of virtual applause. And